I would like to thank Professor Ayman Fakhri, his organizing committee, the Egyptian Venous Forum, and your attention to this important topic, classification and management of venous thrombosis after endovenous thermal ablation.
Here are my disclosures. I have no conflicts of interest with this talk. Early adopters noticed that there was a unique complication with thermal ablation thrombus extension into the deep system. The company, Venous Medical, was keeping a registry of which we mined, and reported in 2002 286 limbs with a 1% incidence of thrombus extension. In 2004, Anil Hingorani and Enrico Asher at the American Venous Forum cautioned all of us by reporting their early experience. 73 limbs with a 16% DVT rate. In 2006, I presented at the American Venous Forum the classification and definition of EHIT. After analyzing many cases from 3 different institutions, it was certain that there were different patterns of extension. EHIT 1, venous thrombosis to the superficial deep junction, saphenofemoral or saphenopopliteal junction, not extending into the deep system. EHIT 2, into the deep venous system, non-occlusive thrombus with a cross-sectional diameter of less than 50%. EHIT 3, into the deep venous system, non-occlusive thrombus, cross-sectional diameter of greater than 50%. EHIT 4, total occlusion of the involved vein. With regard to EHIT treatment, all of us have our own thoughts. Thus, it was clear to the AVF that there was a need to develop practice EHIT guidelines. The American Venous Forum Guidelines Committee organized an EHIT writing group to analyze available literature regarding EHIT, to gauge the quality of clinical evidence, and to provide guidance on EHIT's diagnosis and treatment. These guidelines were approved by both the AVF and Society for Vascular Surgery and accepted for publication in JVS VNL and the Journal of Phlebology. Thus, the AVF updated the EHIT classification by adding to EHIT 1, thrombus without propagation into the deep vein. We added the following: 1A, peripheral to the superficial epigastric vein, and 1B, central to the superficial epigastric vein, up to and including the deep vein junction. Guideline 3.2, treatment for EHIT 1. Just as you would think, we suggested no treatment or surveillance. Grade 2C. Guideline 3.3, treatment for EHIT 2. We suggest no further treatment of EHIT 2, but with weekly surveillance until resolution thrombus retraction. Grade 2C. As an alternative for EHIT 2, consideration may be given for antiplatelet therapy or anticoagulation for EHIT 2, weekly surveillance with cessation of treatment following thrombus retraction to the saphofemoral junction. Grade 2C. Guideline 3.4, treatment for EHIT 3. We suggest treatment with anticoagulation for EHIT 3, weekly surveillance, and cessation of treatment following thrombus retraction to the saphofemoral junction. Grade 1B. And finally, ladies and gentlemen, Guideline 3.5, treatment for EHIT 4. We suggest that treatment should be individualized, considering the patient risk factors, bleeding risk, and reference may be made to the CHEST guidelines for the treatment of a provoked VTE, grade 1A.
Now let's try and answer the question, should we worry? The simple answer is no. Stop worrying about asymptomatic EHIT 1, 2, and 3. Think about the thrombus burden. So let's look at some reasons why not to worry. In 2014, Dr. Jones and I published in the Journal of Invasive Cardiology his perioperative duplex following endothermal ablation of the saphenous vein. Is it worthless? And we concluded yes. Why look for EHIT? So what we know now, The incidence of EHIT in all comers, EHIT 1 through 4, 3 to 4%. EHIT 2, 1 to 2%. The incidence of PE by EHIT at most 0.03%. Are EHITs even dangerous? Our own short series, 10 patients with EHIT 2, all monitored with serial duplex, 9 out of 10 placed on therapeutic low molecular weight heparin, 10 out of 10 had resolution of EHIT within 14 to 21 days. After resolution of EHIT, chest CT showed PE in 2 out of 10 cases. All patients were asymptomatic. None suffered significant sequelae. What does this mean? Let's look at thrombus burden. How much thrombus does it take to cause a clinically significant PE? Nobody knows. Is an EHIT 2 enough? Probably not. Why we shouldn't look for EHITs? The number of thermal ablations performed annually in the United States is approximately 600,000, 60,000 in the United Kingdom. The incidence of EHIT 2 is about 2%, or 12,000 patients per year in the United States, or approximately 1,200 per year in the United Kingdom. The incidence of clinically significant PE from endovenous laser ablation or radiofrequency is about 0.01%, or 60 in the United States, or 12 patients in the United Kingdom. The number of duplexes performed to find one EHIT is 100. The number of duplexes performed to potentially prevent one PE is 10,000.